essentially, my financial disclosure is of course non-relevant to this. Basically, we'll talk a little bit about blunt trauma with associated damage to other structures, and also in terms of what happens long-term after trauma. We are all aware that trauma can cause glaucoma both by an open angle and a closed angle technique, and most common manifestation in an open angle glaucoma is the sort of angle recession that you see there. If you're doubtful about the recession, it's always better to compare it with the other eye, and you can see that the angle is definitely wider open there as compared to here. The reason that you get an angle recession is because of sort of a tear in the iris root, which causes posterior attachment of the iris, and this is the pathology that you see on ultrasound biomicroscopy. But that is not what causes the elevation in intraocular pressure. The elevation in intraocular pressure occurs because of changes that occur at the trabecular meshwork. In the normal trabecular meshwork, you can see the spacings are pretty wide and red blood cells pass through that quite easily. When you have trauma to the meshwork, you have tears which lead to inflammation, and that leads to swelling of the meshwork. And this swelling causes entrapment of the RBCs. It prevents them from going through the meshwork, and the meshwork gets clogged, and secondary to that, you get an increase in an elevation of the intraocular pressure. In fact, the normal pattern of intraocular pressure after trauma is like this. After blunt trauma, you see a drop in IOP, then it sort of picks up, and then late in the disease you can see an increased risk of glaucoma. And the reason for this dip initially is basically inflammation, which causes an increased uveous fluid outflow, and you see a drop in the eye pressure. If you have trauma, you see a reverse of that. You see a spike, and then it continues more or less the same way. But what you must remember here is that in most people, this spike is self-limited. Typically, in anywhere between 2 to 6 weeks, the pressure will settle down in most people. The trick is to identify those in whom it won't settle down and who might require some form of surgical intervention. And this initial increase is because of trabeculitis, hemorrhage, and in rare cases, acute steroid response. This late rise is because of trabecular meshwork scarring, and there is some evidence to show that maybe the patients who develop a late onset steroid-induced, late onset post-traumatic glaucoma are actually more at risk for glaucoma, because very often the risk of glaucoma in the fellow eye also is higher than in the normal population. So we be very conservative about planning surgical intervention early post-trauma unless you are convinced that there is no other option available. So this is what we most commonly see post-acute trauma. So you see a blood clot sitting like this in the anterior chamber, or you might see a little hyphema level with obviously ischemic cornea, elevated intraocular pressures, or a dispersed hyphema with a level over there, or rarely this sort of an 8-ball hyphema. And in which of these situations do you intervene? Unfortunately, there are a few things that we should remember when we deal with this. One is that gonioscopy, when the patient has an acute trauma with few RBCs floating around in the anterior chamber, is not a good idea. You can wait for the inflammation to settle down before you do gonioscopy, because you can precipitate a rebleed by just that act. And these guidelines were given in 1974, suggesting that if you have an intraocular pressure of more than 60 millimeters for 2 days, or more than 50 for 5 days, and more than 35 for 7 days, you should consider doing a wash. And they still hold true because we don't have any newer guidelines in this regard. Maybe you should consider intervening earlier if there is sickle cell disease or at any sign of corneal blood staining. Occasionally you will get rebleeds pretty early in the disease, then suspect a bleeding diathesis. We have at least 3 patients who presented to us with a level, bled again, bled a third time, all within a week, and when we tested them, we found that they all had various forms of clotting disorders and they required to be washed out. And the initial intervention in this situation is an anterior chamber wash alone. But look at the eye very carefully. If you have an eye that looks like this, don't make your entry or your trabecular hemangioma anywhere there. You are very likely to have an iridodialysis sitting behind that, and when you open that, you are likely to have vitreous presenting. So go through one of the other areas if you want to use that. So look carefully at the eye before you make any surgical decisions. Of course, if the eye presents like this with a dislocated lens or a ruptured capsule with inflammation and vitreous and RBCs, it's a no contest. You will have to go into this eye. If you have persistently elevated intraocular pressure even after an AC wash, or very high intraocular pressures even before an AC wash, then you need to consider adding a trabeculectomy to the procedure. And One of the advantages of a trabeculectomy is that if the patient bleeds in the postoperative period, Ravi Thomas et al. Have actually demonstrated that if you can elevate the leg end of the patient, the hyphema drains through the trabeculectomy stoma, and that helps in earlier clearing of the blood from the anterior chamber. If you have something like this, trauma with an anteriorly subluxated lens which causes secondary angle closure glaucoma, then obviously that lens needs to come out. The other situation that you see is somebody who presents to you like this with trauma, a rupture in the capsule, and in the first few days post-trauma you see that lens becoming intumescent. And here you have two mechanisms for glaucoma. One is the secondary angle closure, and the second is the particulate lens matter in the anterior chamber which causes clogging of the trabecular meshwork. These eyes do well with only a lens extraction, either by the anterior or posterior approach. What is to be remembered here is that you need to be careful. You need to be very, very careful about your conjunctival closure and use a conjunctiva sparing method or reoppose it very well, because these eyes are at a long-term risk for coma. I'll just share with you a couple of cases. This was a 25-year-old man who came to us with a history of trauma with a tourniquet to his left eye. He visited us about 50 days post-trauma. He was on timolol, brimonidine, bimetoprost, and on acetazolamide. Intraocular pressures were 32 millimeters of mercury. He had some inflammation in the eye and angle detection. Discs were essentially healthy, even though the large left optic disc was larger than the right, and visual fields were also okay. So we stopped the bimetoprost because he had inflammation. We started him on topical steroids, continued the other medications, and converted the sustained release acetazolamide to one thrice daily. His intraocular pressure dropped to about 20 millimeters of mercury, and 3 weeks later, off the acetazolamide, his pressures were 14 millimeters of mercury. So this is somebody that you don't rush in to treat surgically. You try with medication. Don't forget, trabeculitis is a very, very important reason for an elevated intraocular pressure early post-op. Make sure that the inflammation is adequately controlled. He went ahead to have only cataract surgery, and we could actually eventually take him off all medications. The second gentleman presented us with a history of injury with a wooden stick 45 days back, sudden onset decrease in vision on acetazolamide and dorzolamide, and his visual acuity with a aphakic correction was 618. He had some vitreous in the AC, intraocular pressures of 40 millimeters of mercury, angle recession, and a dislocated crystalline lens. Discs were quite healthy, but this is a situation where intraocular pressures are uncontrolled. You have got an entire crystalline lens disclosed in the vitreous cavity, and that needs to come out. So you would need to do a lensectomy, and you would consider adding on a sclerally fixated intraocular lens at that sitting. And if you are adding on a sclerally fixated intraocular lens at that sitting, you would need to consider adding a trabeculectomy too, because there's a significant amount of conjunctival opening at that position. So this is another patient who presented to us with trauma, subluxated lens. There's some vitreous there, and you can see an iridodialysis. So I'm just going to share with you only the glaucoma part of it. So essentially, cautery, you need to use mitomycin in these eyes because these are at high risk for failure. This is an inflamed hot eye, and we typically use mitomycin for about a minute at 0.4 milligrams per ml. Give it a good wash, and then go ahead and make a flap. This surgery was done along with a vitreoretinal surgeon, and we take care of the glaucoma part of it and they do the rest. So we have the easier part of the deal. And this is the conjunctival opening that they do, and since this case involves not only a lensectomy, it also involves an iridodialysis repair. Ultimately, you have this much of the conjunctiva open there. You have two flaps for the sclerally fixated lens. You have a groove over here for the dialysis repair. You have a corneal section over here through which the lens has been inserted, and you have the two side ports there, plus you have a trabeculectomy opening. So you can see that the whole eye has 360 degree openings at the limbus, and this is a bit of a challenge because when you start doing the trabeculectomy, you're going to have a lot of shallowing of the AC, so it's important that you leave the infusion on before you do that. And even with the infusion on, you will notice that the eye just does tend to collapse. So one of the advantages of having the infusion on is that your iris presents very nicely at the wound. And in this situation, again, what we routinely do is we definitely put in at least one releasable suture, because you may have post-op IOP spikes once initial hypotony settles down. So that, some of our retinal surgeons obligingly do corneal sections to put these clearly fixated lens inside so that we can avoid opening the rest of the conjunctiva. And this conjunctival opening over here, you have two sort of little bridges of conjunctiva on either side, and that helps to enhance the success rates of your trabeculectomy. Essentially here we're just putting a releasable suture with a small corneal tract there so that it doesn't cause a windshield wiper syndrome, and close that down tight. That's very important because this is a vitrectomized, slightly hypotenuse eye with multiple areas of leak through all those openings. It's also important to close the conjunctiva down as watertight as you can, and we typically do that using two interrupted wing sutures and a single mattress suture at the limbus, because this is an eye with multiple possible areas of leakage, and you have to be sure that this is by taking the infusion off with and you can got that is complete. So you have to close that conjunctiva absolutely watertight, because you should be sure that at the end of surgery, if you're having hypotony, it's not because of a conjunctival leak. So in traumatic glaucoma, in acute trauma, wait for surgical intervention. Expect the unexpected whenever you go in. It is a multidisciplinary approach, and you must plan for the future, because don't forget, long-term risk of glaucoma occurs in up to 10% of eyes, maybe even 2 to 3 decades after surgery, after trauma. Thank you.